Hello and welcome to this second session on arterial blood gas analysis. If you have seen the last session part 1, we have discussed about the various sampling error, importance of doing modified Allen's test, indications of ABG in ICU, the importance of oxygen dissociation curve, its relevance to the saturation gap, and also defining of the ABG used for the new definition of ARDS. And we also discussed about the calculation of alveolar arterial gradients. So we gave, starting from the point where we ended, I gave these questions to solve in the last session, where a 40-year-old male on the room here, we wanted to calculate the alveolar arterial gradient and to know whether it is normal for his age. As we know that the oxygenation of the patient can be divided as hypoventilation if it is the normal A gradient, and if it is high, then we know that there is VQ mismatch or other causes for diffusion defect for oxygenation. So in this ABG, we also know the formula to calculate the alveolar PO2. The answer here is that the A gradient is 13 and it is normal for his age. So as the age increases, the alveolar and arterial gradient increases. So just see how we solved it. So by putting it in the formula where we have the alveolar oxygen is equal to FiO2. Here FiO2 is it is better to calculate on the room here. That is 21%, 760 is the atmospheric pressure, 47 is the vapor pressure of water. This turned out to be 713, minus PCO2 value in the ABG is here 30, and respiratory quotient, which we take a normal value of 0.8, or you can multiply 30 by 1.25. So what you get here is alveolar oxygen, that is 113. If we calculate the gradient, so gradient is this PO2, alveolar PO2, that is arterial PO2, and so alveolar PO2 we calculate is 113, so it is coming out to be 13. Now to know whether it is normal for the age, we have this formula of age plus 10 by 4. So here the age is 40 plus 10, that is 50 by 4, that is 12.5 approximately. So this alveolar arterial gradient is normal for his age. This is how you calculate alveolar arterial gradient, useful clinical parameter. Mostly it's best to calculate on the room here. So as the patient require more and more oxygen, to know the shunt, it's better to calculate the PaO2, that is arterial O2 by FiO2, PF ratio, which we for the patients who require higher FiO2, that we discussed in the last session. Starting with this session, the objective of this session is that we'll put these steps of ABG interpretation bedside. Calculating of the anion gap. So we will discuss about the causes of high anion gap and normal anion gap metabolic acidosis, how it helps to differentiate the diagnosis. Also understanding the delta gap, which helps us to find additional metabolic problem associated with the patient's condition. We will have some interesting case discussions. So we will put this ABG in a clinical scenario and see how in various clinical situation the ABG helps us and is affected by the clinical situation, how to interpret in the clinical context. So let's start with the steps. The first step in ABG analysis is mentioned as check validity. So we go clockwise. So check validity, determine the primary disorder. So last time we discussed if the primary disorder is respiratory, the kidney compensate, and if it is the metabolic problem, then the respiratory system compensate. In the part 1 of the ABG session we have discussed. So if PCO2 is more than 40, it is a respiratory acidosis, or if the bicarbonate is less than 22, it is a metabolic acidosis. So this is how, looking at PCO2 and bicarbonate value, we can determine primary disorder. Then determine the mixed acid-base change disorder by calculating the compensatory response, which we will see in one of the examples, where we know that we can calculate the compensation in respiratory condition. We have seen metabolic compensation, and metabolic condition we see the respiratory compensation. So we discuss the various formula, then we calculate the anion gap in metabolic acidosis. Examine the patient to determine whether clinical signs are compatible with acid-base analysis. This is important, and do not interpret anything without the in isolation. So it has to be in clinical context. Then calculating certain additional values like delta anion gap, or calculating the corrected bicarbonate and the osmolar gap in certain poisoning situations where it will going to help. So the first step is checking the validity. So most of the ABG are valid, but if it's not, the values are not matching with what you are clinically expecting, it's worth checking for validity. It's often we discussed in last that is because of sampling error, because of excessive barring, or because of delayed processing, certain changes may happen, and this can be caught in the by checking the validity. So how do you check the validity? So you can calculate the hydrogen ion concentration by this formula of 24 multiplied by the PCO2 in the ABG divided by bicarbonate in ABG. Whatever the value you get from that particular ABG, if suppose you get a H plus of say 63 in the after calculation, you see that the, from this chart the corresponding pH is 7.2. So if you see this pH of 7.2 in your ABG, then it's a valid ABG. Suppose you are getting a pH of 7.5 and H plus of 63, definitely this is erroneous reading, or this ABG is not valid. So this is a simple first step, and keep this chart handy to if you can remember that at 7.4 the H plus is 40. As the pH decreases, it increases by 10. So 7.3 becomes 50, 7.2 is becomes 63, 7.1 become 80. And as you go in alkalotic side, there is decrease in hydrogen concentration. 7.5 it is 32, and 7.6 25. So no need to remember as such. You can have this chart with you, and you can check for the validity of the report. Second step, we discussed about the checking the primary or the secondary primary acid-base disorder, or there is additional acid-base disorder. So we know that in acute condition there is 1 milliequivalent rise in bicarbonate for every 10 millimeter rise in CO2. That in respiratory acidosis condition, we know that the renal system takes certain time. So in acute condition, the bicarbonate will not be absorbed, but after 48 hours of CO2 retention, kidney will start responding, and that's why in chronic respiratory acidosis, for every 10 millimeter rise, there is a 3.5 milliequivalent rise of bicarbonate. Similarly, we see in respiratory alkalosis there are two conditions. In acute condition, there will be drop in the PCO2, there will be drop in the bicarbonate, 2 milliequivalent for every 10 millimeter drop in the PCO2. And similarly, in chronic condition renal system, there will be compensation of 5 milliequivalent per 10. In metabolic acidosis, we have to remember this winter formula to find the expected PCO2, that is 1.5 times bicarbonate plus 8, that is your expected PCO2. And if you find that your expected PCO2 is higher than what is seen, so suppose you get a expected PCO2 if bicarb is 10, patient has metabolic acidosis, and you get say 23, but your ABG shows a PCO2 of say 40, so there is an additional respiratory acidosis. Similarly, if your expected PCO2, what you are getting, an actual PCO2 in the ABG is lesser than your expected PCO2, then there is an additional respiratory alkalosis. So that is how you find primary and secondary acid-base disorder. In metabolic alkalosis, similarly, you can calculate by 0.7 times bicarbonate plus 21 is your expected PCO2. Now going further with ventilation or PCO2, to understand this, as we have already discussed that in acute respiratory condition, the renal system is not immediately compensated. So that's why there will be greater change in the pH, because kidney has not compensated, greater change in pH. So increase in the 10 millimeter of carbon dioxide, there will be decrease in the pH of 0.08. And similarly, in chronic condition, increase in 10 millimeter of increase in 10 millimeter of CO2, there will be decrease by 0.08, but in chronic it will be 0.03 units. From what baseline we have to calculate? We have to take a pH baseline of 7.40. So that is the value we have to take. So 7.40 we have to take. So for each millimeter of mercury you can calculate as a 0.008 for acute condition change in pH, and for chronic condition we can calculate as 0.003. So let's understand it further by example. So this is the ABG of person who is overdosed with opioid. Now we know that opioid is a respiratory depressant, and what would you expect in the pH? So this patient has been overdosed opioid recently, so it's an acute condition. So we expect an acute respiratory acidosis. In the ABG you see a PCO2 of 55. So that means it's a acute respiratory acidosis, rise is by 15. So normal PCO2 is say 40 if we take, so there is rise by 15. So what should be the pH? So if we calculate, the change in pH will be much more in acute, so that is 0.008. So if we calculate it on the right side, you see PCO2 55 minus 40 is 15 millimeter of mercury, and considering acute history 0.008 into for every 15 is 0.12 is the pH change we are expecting. So the pH will be acidotic, so 7.45 minus 0.12, this is typo error, so 0.12, and what we get is 7.28. so 7.2 is the correct acidotic condition. Now if the patient is chronic respiratory alkalosis, the answer is yes or no. So here we see the ABG pH of 7.46, PCO2 is gone down 20. So 40 minus 20, that is 20, and if we consider this as a chronic, we have to calculate the change in pH as 0.03. So 0.03 multiplied by 20. So if we see 0.03 multiplied by 20 is 0.06, and if we add as a alkalosis of the baseline of 7.4 plus 0.06, 7.46, and this is what is observed pH, and that's why this is yes, this is a chronic respiratory alkalosis. Hope you understood this compensation of respiratory with the pH change. Now coming to the anion gap. What is anion gap? There are certain unmeasured anion. Actually there is a electroneutrality, but certain anions are unmeasured, like proteins has a major role, organic acid, phosphate, sulfate, 23 milliequivalent, and unmeasured cation which are positively charged, calcium, potassium, magnesium, these are 11 milliequivalent. So the ABG machines calculate this as a gap, that is anion gap, or you can calculate as sodium minus chloride minus bicarbonate, that is 8 to 12 milliequivalent per liter is considered as a normal gap. So if the gap is more than this value, then you can have differential diagnosis in two different sets of group. So if you have a high anion gap metabolic acidosis clinical condition, you can take a history to rule out methanol poisoning, ethanol poisoning, uremia, diabetic ketoacidosis, paraldehyde poisoning, INH or iron toxicity, lactic acidosis, or salicylate poisoning. These are best remembered as a famous mnemonic of mud piles. Suppose there is a normal gap metabolic acidosis. The most common is excessive saline infiltration, that is hyperchloremic metabolic acidosis. Excessive NS is used for resuscitation. Acetazolamide, Addison's disease, hypoaldosteronism, renal tubular acidosis, diarrhea, bichromate losing diarrhea, ureterosigmoidostomy or ureteric diversion procedures, or pancreatic fistula. So this normal gap acidosis, you have a different set of diagnosis where you can see in clinically. So it can be remembered as a hard up, HARDUP, up. So hyperchloremia, acetazolamide, Addison's disease, renal tubular acidosis, diarrhea, and ureterosigmoidostomy. So calculation of anion gap basically helps us to differentiate the two group of conditions so that we can pinpoint and move towards the diagnosis. While calculating the anion gap, we know that in our critically ill patient, most of the patients are hypoalbuminemic, and low albumin is a anion, so shift towards the metabolic alkalosis side. So we'll get a falsely low normal anion gap, falsely low normal anion gap. So you have to do the corrected anion gap in such situation, and you have to, how do you calculate it? You see the observed anion gap and you have to add the deficiency of albumin, that is 2.5 into 4.5 minus the serum albumin in milligram percent. So that will give you the corrected anion gap. Additionally, there are certain complex conditions where there is a additional metabolic alkalosis, or there is a normal gap, normal anion gap metabolic acidosis in nagma, and high anion gap metabolic acidosis coexist. So how to know that? We can calculate the delta gap. What is delta gap? So delta gap you can calculate from the anion gap minus 12. So whatever anion gap you have calculated, sodium minus chloride bicarbonate, you get a anion gap, you subtract it by 12, and then you see the change in bicarbonate, divide by 24 minus the bicarbonate in the ABG. So if the value is less than 1, or anything between 1 to 2 is a uncomplicated or pure high anion gap metabolic acidosis. If the value is more than 2, there is an additional metabolic alkalosis, that is a change in bicarbonate not matching. And if it is less than 1, then you have this coexisting normal anion gap metabolic acidosis. So this helps, delta anion gap helps to calculate the additional metabolic condition in complex metabolic and acid metabolic status. Let's understand this by cases. So case 1, we have a 24-year diabetic patient, came with Kussmaul's type of breathing, respiratory breathing, and distress and fatigue and loss of appetite. The pH is 7.23, PaCO2 is 23, PO2 is norm 110. This is taken on the room air FiO2 of 21%, and the bicarb, which is a calculated value here, is 14. So what is the primary acid base disorder? So let's apply the step. First, look at the pH. So pH is 7.23, so it is less than 7.40, so definitely it is acidemia. Look at the bicarbonate, is less than 22, yes, it's a metabolic acidemia. What is our compensatory formula we have to apply to see whether it is primary disorder? 1.5 times bicarbonate plus 8. So if we apply 1.5 times bicarbonate plus 8, that is 1.5 times 14 plus 8, it comes around 31. So that is our expected PCO2 is 31. What is the PCO2 here? If we see, it is 23. So PCO2 here is 23, is low, is lower than what we expect. So there is a additional respiratory alkalosis. So this condition, this patient has metabolic acidosis as well as respiratory alkalosis. Now we have to see whether this metabolic acidosis is normal gap or high anion gap metabolic acidosis. We need to have a value of sodium and chloride. So if we have sodium is 130, chloride is 100, the anion gap is 130 minus chloride plus bicarbonate, that is 100 plus 14 is the bicarb here. So we get a 16 value of 16. So that is a high anion gap metabolic acidosis. Underlying condition is diabetes. We have to check for uremia, renal function. We have to check the BSL. We have to rule out diabetic ketoacidosis in this condition. And he is washing out the CO2 is additional respiratory alkalosis because of sepsis or underlying infection. So this is in clinical context how the ABG helps us to approach and how do we calculate the situation. Coming to case 2, this is a young male patient of convulsion, was on regular intravenous doses of benzodiazepine for control. The biochemical profile, here the measured serum osmolarity and calculated serum osmolarity. So if we discussing this case about the concept of osmolar gap. So if we can calculate the osmolarity by this formula of 2 times sodium plus glucose by 18 plus BUN by 2.8. This is a calculated serum osmolarity. If you send in the lab, they do it by freezing point depression method, and there they calculate the measured serum osmolarity is 290. So a slight difference between the measured and calculated, and up till 10 milliosmol can be accepted. So if we see on the day 1, day 4 and day 7 and day 10, there is increase in the osmolar gap. So there is increase more by 10 in day 7 and day 10 and day 4. So there is a slight progressive increase in the osmolar gap. And what is the likely explanation for change in osmolar gap? So whenever there is an increase in osmolar gap, there are additional osmoles which are not taken into this calculated thing. Here we see we not get taken ethanol, methanol, ethylene glycol. So these are all the tests should be done to detect if there is an additional osmolar gap. Now we send this ethanol, methanol, ethylene glycol in this patient. This is not detected. There is something else. So why there is an increase in osmolar gap? Once you have sent everything, you have to check your treatment list. And when we saw that benzodiazepine was given, it was a refrigerated lorazepam which was given frequently. What does the lorazepam have in common? So if you see the preservative ethylene glycol, so glycol is the preservative, and that has led to this increased osmolar gap. So if you don't find anything, look at your prescription, be careful about this condition. Coming to case 3, now this case 3 will take a regular case of the ICU, and we'll see how the pre-existing condition affects the ABG, how the overall it affected by various management intervention, and how the ABG is dynamic. So this is a direct clinical application we'll understand from this patient who is a congestive heart failure. She was on comorbid hypertension and was on diuretic and digoxin. So she came with typically with shortness of breath and fever with productive cough. So the initial impression is this patient is having some lower respiratory tract infection, and naturally on admission the vitals were taken. The temperature was 39, heart rate was 100, respiratory rate she was tachypneic, lung examination showed right basal crackles. The lab WBC was sent 14,000, hemoglobin was 12, sodium 131, potassium 3.4, chloride 98, bicarbonate 29 standard, and ABG was sent because of respiratory distress and pH 7.59, PCO2 31, PO2 58 milliton mercury. So now is the importance of ABG to look at in the not in isolation but in the clinical context, as we have learned in the steps. So in clinical context, if you see there is a high bicarbonate here, there is the pH is alkalotic, so it is more than 7.4. So what are your inferences? So PCO2 is 31, respiratory rate is 30. So if you think for a minute, there is high respiratory rate, so there is a respiratory alkalosis, maybe because of pneumonitis, but at the same time we see a high bicarbonate, that is 29. So this high bicarbonate is causing metabolic alkalemia. Why the patient is metabolic alkalemia? We saw the history. The patient is on diuretic, so maybe metabolic alkalosis secondary to long-term diuretic or volume contraction metabolic acidosis, and that might have mitigated this ABG, the pH of ABG towards alkalotic side. So initial presentation, PCO2 is decreased, bicarbonate upper end of normal, severe alkalemia. So our interpretation will be acute respiratory alkalosity to pneumonia, but at the same time the patient has history of chronic metabolic alkalosis, may be due to diuretics. Initial management, the patient was started on antibiotic, PO2 was low, so we started a nasal oxygen, chest x-ray was advised, sputum was sent for gram stain, gram positive diplococci, and 6 hours later, what is the situation? 6 hours the respiratory rate has become 42, so she's become more tachypneic, BP is normal, heart rate is 120 by 120 per minute, and ABG was done. So ABG is 7.4, PCO2 is 48, and PO2 of 50. So this is decision point. So in ICU, a newcomer will say, okay, the blood pressure is normal, hemodynamically stable, the saturation is say borderline 84-85% on nasal oxygen. The first instance or response will be, let's take this patient on high flow nasal cannula, or let's take this patient on non-invasive ventilation since he is hemodynamically stable. But here is the what additional importance of doing ABG comes into picture. And if you see, the PCO2 is 48. So despite the respiratory rate of 42, if you are getting a PCO2 of 48, you are definitely going to fail in your non-invasive ventilation. And this is the time you have to integrate the values of clinical, and you have to decide to go ahead with invasive ventilation, because this shows the respiratory acidosis. Despite so much tachypnea, respiratory acidosis means the patient is fatiguing. pH is looking normal, 7.4, but PO2 is a severe respiratory failure, type 1 respiratory, type 1 plus type 2 respiratory failure. So PO2 is less than 50. So this patient, though hemodynamically stable, will require the invasive ventilation, and there is a worsening of the condition. So there's a PCO2 of 48 reflecting respiratory acidosis. However, we know that there is a pre-existing bicarbonate is there, so the pH has not gone to severe acidosis, so that is mitigating the effect of our pH, so pre-existing condition of metabolic alkalosis. So this has to be kept in mind when you are evaluating at the bedside clinically. Now this patient was rightly taken on control mode of ventilation. Tidal volume were given as per predicted body weight. So FiO2 of 100%. Of course, after positive pressure ventilation, we expect sedation, other effects. Positive pressure causes drop in the blood pressure. Fluid challenge was given accordingly. 2D echo, IVC was seen, dobutamine was started, and this ABG was done after taking on steady fast state of 20-30 minutes. The pH was 7.24, PCO2 38, PO2 of 86, and bicarb of 16. The anion gap calculated was 23, serum lactate was 8. So we were right in our decision of invasive ventilation. This patient has worsened. There is a metabolic acidosis here seen with additionally PCO2 is high, and the high anion gap, metabolic acidosis pointing towards lactic acidosis and respiratory distress. Now this expected PCO2 has to be calculated is also more. So this ABG tells us that the patient has was in the process of undergoing severe metabolic acidosis due to sepsis, and we have to we have to manage it according to our sepsis protocol. So the blood pressure improved. We managed the hemodynamics. Heart rate was 100. The next day patient seems to be improved. The FiO2 has come down to 0.5 and the PO2 was 72. pH has normalized from 7.2 to 7.34 and PCO2 is 38. So oxygenation is improved, and because of this the patient was started on the TPN for nutritional support, partial parenteral nutrition, restarted on diuretic. Somebody suggested diuretic was already on, so it will help in weaning. So patient was already on pre-existing diuretic, so let's start, and it was started. And what we see after some time was a dynamic change in pH to 7.34 to 7.5, alkalemia, PCO2 44 and bicarbonate of 38. So you see how these dynamic changes are happening on the background of management of the patient, and the final acid-base disorder was alkalemia, here pH of 7.55, PCO2 44 and bicarbonate of 38. So initially it was thought because probably we have put diuretic too early, so again the diuretic was asked to be omitted. So the furosemide was discontinued and the acetazolamide was carbonic anhydrase inhibitor was added, and what happened was the ABG has again worsened. So final acid-base disorder, again the pH became 7.6, alkalotic, PCO2 46 and bicarbonate of 44. Now is the question, what is happening and where the things are going wrong. So if, as I told earlier, if we see in clinical context any ABG not matching and there is some problem, you have to check your prescription, check your all the drugs, and finally we checked all the things which patient was receiving medication substances, and the patient was of course receiving the parenteral nutrition. Parenteral nutrition has the effect on ABG with 70 milliequivalent of acetate being converted to bicarbonate and giving rise to metabolic alkalemia. So this was the additional thing which is pushing the patient into extreme metabolic alkalosis. So this was resolved with oral potassium supplementation, TPN was discontinued, enteral nutrition was started, and the bicarbonate decreased from initial to 26. The pH now has normalized to pre-intubation levels of 7.42 and she was successfully extubated and recovered. So what this case highlight is that ABG has to be always put into clinical context, not in isolation. We have to be very careful about pre-existing diseases, like in this condition patient has metabolic alkalosis to begin with because she was on long-term diuretic, that mitigated the degree of pH change, and that did not mask the severity of the disease condition where the patient landed in severe metabolic acidosis. because of infection. So acid-base equilibrium in ICU is dynamic system, and we saw that multiple disorders may occur simultaneously. Most acid-base disorders resolve with the treatment, although you have to look for the underlying cause. Like here we found the underlying TPN was responsible for additional acetate and do not require correction of pH. All metabolic acids do not require to be corrected with soda bicarb or injection or additional load. Try to treat the underlying cause. Unexplained disorders, of course, should prompt through thorough search of all administrated substances. So that is all for the arterial blood gas analysis. Thank you very much. You can email your queries. Thank you.